I forgot.
You're fine.
Okay. So, first we'll look at the sympathetic pathway. So here we have a sympathetic fiber here in the spinal cord, and it comes out, like we learned, through the white ramus communicans into the sympathetic ganglion, sympathetic trunk ganglion, and synapses either can synapse with the post-ganglionic fiber and head out the posterior and anterior rami of the spinal nerves, or like we have learned with the splanchnic nerves, just continues on out of that that ganglion as a preganglionic fiber to the viscera. Now in this example they're using the greater splanchnic nerve. Well, let me not cross it out. There we go, greater splanchnic nerve. So it's going to go to the celiac ganglion, one of the celiac ganglia in the celiac plexus, and synapse with its post-ganglionic fiber there. So we have the synapse there. And then that post-ganglionic fiber then comes into the target tissue. Okay, so this is typical of the splanchnic nerves. And remember, we get that innervation from all the splanchnic nerves coming down from the thoracic spinal levels, and also coming up from the word I'm looking for, sacral spinal nerves. So then we also have the parasympathetic. So that's sympathetic, parasympathetic. We have, remember, the vagus nerve or the vagal trunks coming down from the thorax. And we also have the excuse me, pelvic splanchnic nerves coming from the back. We'll use the vagus nerve as the example for today. See how it comes down, and though it may pass through the ganglia of the prevertebral plexus, they do not synapse there. Remember, they synapse with their postganglionic fiber here and the wall of the target organ. Okay. In addition to having the motor nerves that are controlling the viscera and all of that in these parasympathetic and sympathetic fibers, we also have afferents. So we have afferents that travel back up the vagal trunk all the way up to the vagus, where the vagus nerve comes out in the cranial nerves section, or we have some that travel in through the sympathetic pathway and go into the spinal cord through the posterior root and have their cell bodies in the spinal ganglia. Okay, so remember our afferent pathways and our efferent pathways. So the vagus nerve and the splanchnic nerves are efferent, right? Wow, I can't spell efferent today. Efferent, okay. Put an E over there. Or then we have also our afferent nerves. Okay, any questions? Okay. So then, considering the splanchnic nerves, remember I asked you to learn what spinal level they came out of? Well, this is where it actually starts becoming applicable, because we're going to talk about where their referred pain is. So, and also how it relates to the arterial supply of the gut. So, remember we have the foregut, and what is the foregut supplied by? The celiac trunk, right? Okay. So it's also innervated by the greater splanchnic nerve, right? And so we can remember splanchnic nerve goes with foregut with celiac trunk, okay? And then your referred pain would be in lower thoracic and epigastric regions, so up in that area there, okay? Then we have the midgut supplied by the superior mesenteric artery, right? And innervated by the lesser splanchnic nerve. Hindgut is the inferior mesenteric artery and the lumbar splanchnic nerves, okay? And then we referred pain here to the flanks and groins and thighs, okay? So I just wanted to point those ones out, but do know all of these in this table. Know which organ is innervated by each splanchnic nerve, and where the referred pain, the pain will refer to from that organ. These are all very useful diagnostic tools. Okay. All right. So onto the posterior abdominal wall. So we have 4 major muscles on the posterior abdominal wall. We have here the, cross out the name. What is it? The quadratus lumborum, right? Okay. So that's right at the back of the posterior wall. Coming around towards the anterolateral, we have the 3 layers of muscle, and they are the external oblique, and yep, good. And then we have the 2 muscles that come from the lumbar vertebrae down to the lower parts of the iliacus, and also the iliac crest. Oof. Never mind, I'm not even gonna try to say that today. And the upper leg, so that's the psoas major and minor you guys have been learning, and then also the iliacus in that anterior surface of the ilium, whatever. Today's not a good speaking day, apparently. Okay, so that should be all good review. If we look at the superior abdominal border, there's just a few things I want to point out beyond what we've learned so far. I just want to point out the inferior phrenic arteries branching off the abdominal aorta, so here and here, and they supply the inferior surface of the diaphragm. Does anybody remember what arteries supply the superior surface of the diaphragm? Also sends branches to supply the pericardium. Use those words to remember the name. Pericardiophrenec nerve, or not nerve, artery. There we go. Yes, good. And then also remember we said that the phrenic nerve penetrated the diaphragm and then innervated from the underside. So here we see the branches of it coming out from where it penetrates. Okay. Okay, so those are the 2 things I wanted to point out for that, the inferior aspect of the diaphragm. Okay, so then we move on to the components. So obviously we have the abdominal aorta and inferior vena cava. We also have the kidney, suprarenal gland, and ureter that all are located on the posterior in the posterior abdomen. Some that we haven't talked about also are the gonadal vessels that we'll talk about in a little bit more detail in a moment. But just those additional components we're going to talk about for this lecture. So, remember, does anybody remember, are the kidneys peritoneal or retroperitoneal? Retroperitoneal, right, and that's because they're covered with the layer of the peritoneum, located right about the level of the pancreas and the duodenum, so kind of in that upper level of the abdomen.
Could you go back to the other image for a minute?
Yeah, that one?
Yeah, where it's showing the gonadal vessels.
Mm-hmm.
Is that just saying like the combination of both the artery and the vein?
Yeah, it's pointing to both of them where they're intertwining here.
And so the vein comes off the renal vein.
Yeah, so the left gonadal vein comes into the left renal vein, whereas the right gonadal vein comes straight into the IVC.
Do you want us to know this, like the distinction of where those, like I know in the body we do, but like for our purposes here, do we just address it as the gonadal vessels?
We'll talk about them more later in more detail, but for this slide, we're just kind of getting overview. But yeah, you will need to know where they are, and then obviously in the female it would be the ovarian arteries and veins, and then the males, it would be the testicular arteries and veins. And so when we actually talk about the reproductive systems, we'll get into that in more detail.
Thank you.
Okay. So then here's a nice cross-sectional view. You can see the kidney right beneath that peritoneum here. And then also I want to point out the perinephric fat. So this is a layer of fat that surrounds the kidney, helps cushion it. Okay. I also, you can see kind of the arrangement of the several lower abdominal, what's the word I'm looking for? Muscles, good grief, like the quadratus lumborum tucked in right here on the posterior abdominal wall, the psoas muscle here. So start familiarizing yourself with those cross-sectional diagrams again, making sure you understand the spatial arrangement of each of these, excuse me, each of these structures. That's what I'm looking for. Okay. All right. Exteriorly, the kidneys are typically very close to where the floating ribs are here, a little bit below them. And remember, the right kidney is placed just slightly lower than the left kidney. And then the two hilum of the kidney, so the areas where all of the vessels and everything enters the kidney, is about the level of the first lumbar vertebra. Okay. So then you guys have already been studying the internal anatomy of the kidney, so we're just going to go with, you guys have been learning the structures on the lab list. Those are the same ones you'll need to know for lecture. What I just will point out, just to make sure that everyone's clear on this, is that it's in the renal medulla that all of the filtration happens. This is where the nephrons are located. Remember, they've got the funny little arched tube structure, and then it is at the renal papilla where the collecting ducts open. So that's that last part of the nephron, the collecting ducts open on the renal papilla. So if you take a micrograph of the end of the renal papilla, you see lots of perforations, lots of ducts coming out into it. Okay. Other than that, know this as well as you know the diagram, or the models and the kidney and the cadavers. Okay. Okay, so vasculature of the kidneys, and this should be suprarenal glands to be accurate, because the adrenal glands and some additional glandular tissue. So I was tired when I was writing this last night, obviously. Suprarenal glands, okay. So the kidneys get their vasculature obviously from the renal arteries and then the renal veins coming back from the kidneys. And then we have additional branches for the suprarenal arteries, and we've got the inferior branch, the middle branch, and the superior branch. So as you can see, there is multiple different blood supplies. So lots of blood supply to the suprarenal glands. Excuse me. And lots of redundancy in it. So because it's a hormonal gland, it's got to have a lot of circulation coming through it. And also, since it's so important for balancing stress responses and all of that, that is important to have redundancy to the vasculature. One thing I want to point out is where this renal vein comes in under the superior mesenteric artery. And anytime you have a structure that is passing in between two other structures, you have possibilities for cutting that structure off, right? So if you have, say, like an aneurysm, a ballooning of the abdominal aorta in this area, or a blockage of the superior mesenteric artery, that can close off that little canal that the renal vein is flowing through and actually impede blood flow through it. ending up causing backup of the blood in the kidney. Okay. Excuse me. Another thing you can have is if you have stenosis of the renal artery. This can lead to problems with controlling blood pressure. So the kidneys are one of the major long-term blood pressure control mechanisms. So they are what balances water retention to increase blood pressure. So if there is some sort of blockage through like atherosclerosis or something like that to the renal artery, blood flow is going to decrease to the kidney, and it's going to detect that as a drop in blood pressure. And so then it will start causing the body to retain more water. It's going to stop secreting as much water to try to get that blood, its perception, there's the word I'm looking for, of the blood pressure up to what is normal. And this can actually be, it's one of the least common methods of developing hypertension, but it does exist. It can have that happen. That makes sense? Any questions? Nope? Okay. All right, so then we move from the kidneys down the ureters into the bladder, and there's just a few things I want to point out for those. First of all, there's several constrictions of the ureters, so anywhere it passes against a more solid object. So at the ureteropelvic junction, also at the pelvic inlet as it's coming up over the lip of the pelvic inlet, and then also as it enters the bladder, these areas can't expand as much as the rest of the organ can. And what would be a clinical relevance for that? Anybody have an idea? Kidney stones, yeah. So kidney stones are most likely to be lodged in these constrictions. And does anybody know what a kidney stone is? What is it made of? Often it's a calcium compound. I'm blanking on what it is at the moment, but whatever. Anyways, it's precipitates of what's in the kidney, the renal pelvis, and as it becomes super saturated, especially if somebody does not drink enough water or has extra calcium secreted or something like that, they form these stones, and these aren't nice little smooth stones. They're nice jagged, sharp-edged, wonderful things. My poor father. And then as they move from the kidney down the ureter, obviously it scrapes and bumps its way all the way down and causes mass amounts of pain. And there's a couple of ways they get rid of them. They can use high-frequency sound waves to break them up, and then they are passed more easily because they're not as big, obviously, or they have to go in and surgically remove them. Sometimes they get big enough they're actually trapped in the renal pelvis. They can't even get into the ureter. And in that instance, they have the possibility of blocking off urine flow from the kidney through into the ureter, and actually can cause renal failure by that blocking off. So just so much urine gets backed up in the kidney, it can cause renal failure. And in those instances, they have to go in and actually take it out of the kidney. I did have that done this last year. It really was not a fun experience for him, poor guy. Another thing is that the ureter has layers of smooth muscle, and excuse me, it also constricts slightly as it moves urine through, and so anytime it constricts around the kidney stone, that's when you get those waves of pain that you experience with a kidney stone. Another thing I want to point out is all of the little tiny arteries that are supplying the ureter. So we've got a little branch coming off the internal iliac artery, a little branch coming off of the common iliac artery, branches coming off the testicular arteries, and then also branches coming off the renal arteries. And just note how small and fragile they are. And this is another thing with anything when you're doing any surgery in this area, these are very easily broken. And so, excuse me. If they are broken, then that cuts off blood supply to that area of the ureter, and that can actually become necrotic and die. When that happens, they have to go in and replace that portion of the ureter with a synthetic structure. Okay, any questions? All right. Okay, so some abnormalities in kidney function or kidney anatomy based on disease. So one of the major ones is renal cancer. Renal cancer is incredibly invasive. So it doesn't metastasize much, so it doesn't send off things to the other parts of the body, but it invades nearby structures very readily. So here's a couple of examples. So this one you see the left kidney, this is what it should look like. Here's the right kidney. It's enlarged, and you can see a continuum of a tissue structure into the duodenum. So this is very, very likely that this particular renal cancer has invaded the duodenum. In this one here, we can see an example of slightly less drastic kidney tumor, but you can also see, again, enlargement and abnormal shape of the kidney, and also infiltration into the renal vein here. So, excuse me. Now when it infiltrates into the renal vein, it can then put pressure on surrounding areas. So remember, when it goes right through in between the superior mesenteric and abdominal arteries, those issues can crop up. Okay, in many cases you have renal failure. So this is sort of indirectly disease-induced, but this is just an image of a transplanted kidney. So typically they transplant a single kidney that's sufficient to filter a body's blood, and they transplant it into the pelvic cavity, so into the iliac fossa. So here in the pelvis. You see it's displaced the bladder off to the side rather than the bladder being in midline. And then they connect it with the internal iliac artery and vein. So for the blood supply. Okay. Okay, any questions? Nope. Okay. So then we've gone through most of these before, but I like this image because it shows the few additional branches off the abdominal aorta that we just talked about. So we have the inferior phrenic arteries here coming off above the celiac trunk. And then also the testicular ovarian arteries, aka gonadal arteries, coming off of the abdominal aorta between the superior mesenteric artery and the inferior mesenteric artery. So use this one to help you get spatial orientation of where all those go. And one more I want to point out are the lumbar arteries. So these are arteries that are supplying the muscles of the lumbar area, and they're branching off the posterior aspect here, etc. Supplying lumbar areas, as their name suggests. Okay. Okay, so then another little clinical tidbit. So the aorta actually is relatively susceptible to aneurysms. What is the technical definition of aneurysms? Anybody tell me?
Weakening of the wall.
Weakening of the wall causing what they call ballooning. Exactly. So you can see here an aortic aneurysm. This is a 3D rendered CT scan with vascular contrast material. So you can see the ballooning of the aorta there, aneurysm. I guess they're actually relatively common, especially in older people, as the blood vessels become less resilient to the stresses of the blood flow through them. But they're not a problem unless they rupture. When they rupture, then you die really, really fast. But many people live through their lives with a aortic aneurysm and never know it or never suffer any ill effects from it. If they feel it's going to be a problem, they can do a couple of different repair techniques, and I really couldn't spell last night. Let's see. I blame the presidential debate. Okay, so one possibility is putting in a stent here, and this is just a meshwork that's inserted inside the vessel to strengthen it. And another option is they can actually excise the aneurysm and replace that whole section of the vessel with a synthetic vessel. Those are two options that are commonly used in aneurysm repair. Okay.
What was the first one you said?
Putting in a stent, so this is an image of a stent. And then also you can use synthetic vessels. Okay. All right, so then we've got the arterial supply, and then we have venous drainage here. So a few things that are familiar: the azygos vein and the hemiazygos veins, they actually arise initially in the abdominal area, and then continue on up the thoracic region. And I want to just point out the lumbar veins here. We have several different versions: iliolumbar, ascending lumbar, and then just lumbar veins. Just know them as those veins that supply or drain the same areas that the lumbar arteries supply. So this is going to be draining the posterior abdominal structures. Okay. There we go. Okay, so kind of use this as a, learn those few extra ones and then use it to connect the vasculature of the thorax with the vasculature of the lumbar area. Okay, well, I'm blazing through this. Good grief, take a lot less time than I thought it would. Okay, so next thing is the lumbar plexus. So this is a somatic plexus. And it's composed of spinal nerves coming out of the lumbar vertebrae, as well as some parts of the subcostal, so that's the T12 nerve, and they all come together in this meshwork here. You can see it kind of excised and dissected out in this image, but actually they run in through the psoas muscle, so a lot of them actually pass through the psoas muscle. Excuse me. You don't need to know all of the details of the names. I do want you to know that the upper portion typically innervates the abdominal wall, the gluteal region, and some pelvic and genital structures. Yep, we can do that again. So the upper portion of the lumbar plexus partially innervates the abdominal wall, the gluteal region, and some pelvic and genital structures. Okay. The lower portions, oh yeah, sure. Let me know when you're ready. Yeah, so here, I could do this. So abdominal, gluteal,
It's just the upper plexus, lumbar plexus.
the upper parts, yeah, pelvic and genital. you go. And then the lower portion also innervates parts of the genital region. Whoop, can't spell today. And then parts of the lower limb, so the thigh particularly. Okay, one I want you to know for sure is the femoral nerve. And it is branches of the L2, L3, and L4 spinal nerves. And this obviously goes down to the lower limb. Okay, so any questions on anything in the abdomen? Because we are done a lot faster than I thought it was. And not talking as much as I usually do, I guess. So we can use this time for a little bit of question answer time, or review anything that you guys are still struggling with.
Should we still primarily focus on your lecture notes after that?
Mm-hmm. Yeah, lecture notes and lecture slides. If it's on either one of them, or I point it out on a lecture slide.
Did you say also that if you do graphs on this next test, please do the word bank?
Yeah, so I've done all of the questions as multiple choice now, even the diagram questions. So you'll just be choosing the correct out of the possible 4 options. Yep.
Will it be like on the computer then?
Well, let's see how the quiz goes this Friday. There was a lot less problems in this room, I see. There was only a few people that were having some issues. So if the quizzes continue to go better in this room, it'll be easier to do that on the computer, partially because you get immediate feedback. You don't have to wait for me to do scantrons and all that stuff. And also, it's easier to have access to the diagram you're looking at, or needing to look at that time, instead of having to wait for the slideshow to loop through and all that. So there's a lot of advantages to it as long as it's technically going to work. So
If it is on the computer, can we have like a scratch paper?
absolutely, I'll bring a scratch paper. Yeah. Any other questions? Is there any aspect of what we talked about in the abdomen, or that you studied in the lab, that you're just like, I'm not sure I'm putting it together, and we could go over that? Or are you guys pretty good? Okay, well then have an extra half hour of freedom.